plan and it's all yours. Best of luck.
Thank you.
And we are live now.
Good afternoon, I'm Anne Holden, I'm the Director of Medical Education here at Southport, and welcome to our Grand Round this week. I'm very happy to welcome Dr. Patel, who is the Associate Dean for Southport, who was due to present a couple of weeks ago with one of our foundation doctors, Dr. with Konyan, who was basically talking about racism. Dr. Patel gave this presentation about 18 months ago at a meeting that I was at, and actually I found some of the data quite surprising and at times really quite shocking. She tells me that work has been ongoing as a consequence of this data, and therefore she's going to provide some update and some information. But I think this is something that we all need to pay attention to, and so I'll hand over to Dr. Patel.
Thank you, Anne. That's very kind of you. So as Anne said, I'm one of the postgraduate associate deans, and I work also as a renal consultant at Manchester Royal, and I have various college and educational roles. So what I'm hoping to cover for this afternoon, and my talk as an outline will be around, half an hour, sort of probably not much longer than that, and then hopefully we'll have some time for questions, because I think the discussion around this is always quite helpful. And what I would wish to do as my outcomes for the session would be to just raise awareness of some of the research work, some of the evidence around differential attainment, and then understand the challenges of addressing differential attainment. And the kind of work that I've been involved with is exploring strategies to address differential attainment at more of a programmatic cross-specialty level, and been working on some potential interventions in order to try and narrow the gap and improve outcomes. So how did I get involved in this kind of piece of work? So as I mentioned, I've been doing various educational roles over the years, and I had an interest of trying to support trainees in difficulty some years ago in my previous role as a training programme director for renal medicine for the Northwest. And as part of that, we were looking at, so my master's thesis around that time was around how to identify and support trainees in difficulty. And when I looked at the regional data, which is the DDRG, the Doctors Dentist Review Group data, the GMC provided some long-term progression data. And when I looked at the outcomes, it evidenced differential attainment. And I'll talk about what that is and how that's evidenced in a bit as well. And then I did various reports for the college, which was looking at training in the UK. And this also evidenced variation in outcomes from an END perspective. And more recently, I'm involved in looking at, kind of a national END study or EDNI study, looking at quality criteria and educational outcomes, and particularly looking at the educational environment, because I do feel it's not just about the trainees and a deficit within them, it's how the environment and how we can support trainees better as well. And over the last few years, I've been member of the HEE Northwest EDI group and also the GMC advisory group as well around EDI issues. And we've been the pilot site in the Northwest for some of our outcome data for differential attainment, and I'll talk about the metrics as well as I go along. So just starting off, what is differential attainment? And I think this is important to understand. So it is the unexplained variation in the attainment of groups of individuals who share protected characteristics when compared with groups who don't share the same characteristics. And it could be across the whole spectrum of protected characteristics. So a lot of the work I'm going to share today is based on ethnicity and background and primary medical qualifications, but this could be by gender, this could be by disability, all the other protected characteristics as well. And the other way of thinking about it is fairness as a concept in education. And one of the definitions around that is making sure that whether it's your personal or social circumstances, for example, gender, your background, ethnic origin, and that in itself should not be an obstacle to achieving educational potential. And that in itself is quite close to my own heart. I have various protected characteristics, kind of being Asian, female, less than full-time in the past, as well as, coming from a sort of maybe a less affluent background as well. So all those things as a compound should not be an obstacle to achieving educational potential. So what is the scale of the issue? And this is what Anne was referring to when we were talking about the numbers and the data. So this is some of the earlier data that, and this still holds true, unfortunately. So we know that different groups of doctors progress through training at different levels. It exists across all measures of progression, and the widest gaps is within postgraduate examinations, and the same occurs in undergraduate examinations as well. So when you look at the pass rates for UK white graduates, that's as high as 75%. This is cumulative, all specialties, all programmes. And when you look at the Black minority ethnic groups, the BME group, that's like myself, it goes down to 63%, the pass rate. And when you look at international medical graduates, this is really striking. It goes right the way down to 41%. And that doesn't mean that everybody attains badly, but certainly this is what the figures show. And we know it's existed for many years. It's not easy to address. What the research shows is that the variation is not easy to address, and it could be as a variety of social, economic and cultural factors. And we know that we can't rule out discrimination and bias as well. So when you're trying to understand differential attainment and the causes of it and how you can make an improvement or a change, I think it's useful to look at it in different ways, and I found this as a concept really helpful. So you can look at it from the way of individual learning styles. So this, as an educational supervisor, you can think about how learning styles may be different, how the culture and the interactions, how their networks and support might be different. And that's how we as supervisors and educators may influence outcomes of individuals as well. You could look at the meso level, which is more probably the deanery or, you know, the local offices level, around how recruitment works, how induction works, how support, assessment, ARCPs work, and how those processes could be fair, equitable across the board as well. And that's some of my work within the deanery kind of role that I do. And then at a national policy level, this is kind of some of the work that I'm involved with the college as well. How exam structures work, how the curricular development works, and how we can influence at that level as well. So different levels, and like I say, each of us as an individual is able to, I feel, influence at least one of these levels. So why is it important? So I think, you know, there's a moral argument, there's a legal argument, there's, you know, this is the right thing to do. That's certainly what I feel. And from the GMC perspective, it's a legal requirement to investigate these issues. It's the responsibility of HEE, the trust, the local education providers like yourselves, to ensure that there's fairness and equity for all. And we know that we all lose out if doctors don't receive the support or the opportunities they need to achieve their potential. And it's a loss situation if people are not supported. So I think it's really important to ensure if there are barriers to progression, we need to identify those and make sure that if they are there, they're valid, fair, justifiable, and this all is important to protect patients as well. And if there is any evidence of actual bias or discrimination, then that needs to be addressed quickly. And I'm by no way saying that it's all about discrimination or bias, but I think, you know, those things do need to be also considered. And over time, I think as a system, you know, I would hope that if there's a system change, we would aim to see reduction in these rates of progression over time. So from the GMC side, so I work also in my other capacity within the GMC with this piece of work, as well as some of the EDI issues as well. And what's important is that we need to build capacity in organisations for delivery of medical education to engage with these issues. And I was just speaking to Anne to say that this should be more part of core business and not just an add-on of something that is good to do. We need to facilitate evaluation and sharing of learning from interventions that worked. We need to look at the data, what's out there, and share that, not be scared of that. So for many years, the GMC was sitting on this data because it was something that they were worried about. And in the years gone by, when some of this data came out, there was a challenge from the GP college as well around the fairness around exams and things. So there was a little bit of kind of defensiveness around sharing, but I think that is the best way forwards to get the discussion growing and then discuss how you progress, improving things and trialing things. And like I say, it's a wider healthcare system issue, and we need to ensure that we're collaborating across the whole system to drive the change. So what are the metrics for differential attainment? So differential attainment, we know it's not just about postgraduate exams. So, you know, kind of the other measures of progression that we can measure are around ARCP, unsatisfactory outcomes, exam outcomes, and then the GMC look at their NTS, the National Training Survey, and then the overall satisfaction score could be a measure where you're looking at the broader educational environment. Because as I've mentioned from the outset, the environment of training is really important to drive learning, and that needs to be looked at as well. So that as a composite score is what we look at when we're looking at the metrics around differential attainment. And the data that was shared with myself over the years, which I work on, is given by specialty and training programme level. And what does that data look like? So this is a busy slide, but this is what the GMC Connect data is available now to look at. And it's a bit like your traffic light system or the, you know, the green and the red outliers for the GMC training survey. But if you look at this is this year's data. So you're looking at combined specialties, and I've just put down some programs just to give a bit of a sort of a feel of the data. So this is showing ARCP exam outcomes and the overall satisfaction scores. And this is the UK white population against the BME sort of group. This is the European trainees, and then this is the international medical graduates on the right. So this is showing that in the ARCP outcomes for all specialties, there is an outlier of 95% below outlier for the ARCP outcomes. The same for the exam outcomes, and slightly less significant for the satisfaction score. So that's between the BME group. And in the European group, there is a difference again between ARCP and exams, and the same again for the international medical graduate group. So this is quite striking to say it's across all specialties, and basically in some programs there is more or less of an issue, but it is an issue in the majority of programs. And there is still a bit of an understanding of, oh, it doesn't happen in my specialty. But when I've looked at the data across, it's probably across most specialties, but some are better or worse in some specialties. And I'll talk through that in a minute as well. So what's important to then consider, and when I do this as more of a workshop, I always ask these questions. And when we come to the question set at the end, it'd be helpful to share some thoughts if you're able to kind of think, what kind of issues do you feel may contribute towards differential attainment outcomes in your specialty, programme and trust? And more importantly, how can we narrow the gap and improve outcomes? And what can we do at an individual level, your own self as a supervisor, as a trainer, as a clinical lead, at a local level, trust or practice if you in general practice, and then at a regional level in the kind of roles that I do within the deanery, programme, school level, or at a national level. So depending on your roles, where do you feel that you may be able to influence and change? Because I do feel every little bit helps, and it's one of those that you always think, gosh, it's too huge a problem to address, but we all need to start somewhere. And I think the more people thinking about it, I would hope that in itself will drive the change over time. So what are the perceived causes of differential attainment? So this is some work done by Catherine Wolfe, which is the Fair Training Pathways, which I was involved with some years ago. And this looked at various factors, so involved for focus group discussions as well as individual interviews that I took part in myself. And some of the factors are around relationships at work, with your seniors, with your peers, the curriculum, how you learn, are the assessments fair? What about the hidden curriculum? Do you get to learn that when you start from, say, a different setting or a different country? And the capital aspect, there's different cultural differences around perception and the well-being and identity. I think that's a huge, huge issue. And some of these things around bias, fitting in, belonging, I myself talk about, despite being born and bred in the UK, sometimes there are issues around your own identity, which then affect your relationships with your seniors. And then it's kind of that kind of interplay of different issues which may affect this as well. So then when you think about the risks and the vulnerability side, what is the protective things? What can you do to drive the change? So if there's poor relationship with seniors, if that's the perception, then as trainers, we can try and have a bit more time to get to know our trainees, having faith in their abilities. I remember one of my international medical graduates who was preparing for his MRCP exams, and I was his supervisor a few years ago, and he said, well, what's the point? I'll probably fail a few times before I get there. And you think, well, no, you shouldn't be thinking like that. So having faith in their abilities, supporting them. If there is anxiety around lower confidence, then how can you support with exam support? And then it's moving away from that deficit model of not being the fear of the feeling as though that you're going to be the problem, but it's trying to be proactive as an educator to support, giving tailored advice if need be, and then moving away from the negative stereotypes to the more positive modelling and role modelling side of things to give aspirational advice as well. And sometimes it's just obvious things like practical difficulties and things that which you can help with, or certainly signpost to and offer support as well. And a lot of people may not have that support or the networks that others may have. So how can you, at least being aware of that and then supporting, would be all, contributing towards helping with these things as well. And then this was work done with the work psychology group that I'm involved with in East Midlands. And they looked at in the programs which had the least differential attainment, what were the things that actually made those programs successful? So simple things like when you look at the working and learning environment, diversity just being valued, simple, just valuing that rather than making people feel different in any way. And looking at the learning pathway as a continuum from medical school foundation, breaking down the barriers between undergraduates and postgraduate and seeing the education and training as a whole. And then the question around who supports learning, things like inspirational seniors, supportive trainers, peers, is what helps, kind of training move forwards. And the what is the maximising value of learning, being treated as an individual, not as somebody is going to, already been treated as a failure as well. And then simple things like working arrangements, less than full-time options, if they are having a challenging time, kind of trying to support on a more individual basis. And I talk a lot about more holistic educational supervision, trying to take people as a whole, not treating our own responsibilities as a tick box exercise as well. And then again, some questions for you later to think through is how can we better as training providers facilitate success, and how can more broadly colleges as well as organisations support success as well. And then the other way, when I look at interventions of what we can do to try and improve things, you can think about it through the GMC postgraduate sort of medical education themes and standards. So how can you make the learning environment better? Do they need an enhanced induction? What can you do to make sure that your environment is more inclusive, supportive, to support your trainees as well? Looking at the educational governance side of things as well, how is recruitment working, selection, are the placements based on educational needs? Are there less or full-time options? What are the qualities when you're looking at supporting learners around educational supervisors, and what should they be doing, offering pastoral support, other things as well? And then how can we support our educators as well? So in addition to supporting the trainees, we need to support our educators to support the trainees as well. And then looking more broadly around curricular and assessment as well, and thinking through about tailored support if that was a requirement as well. And when I've done focus groups with both trainees and trainers, these are some of the things that come out as interventions that we could potentially do. And I know this session's being recorded, and I'm very happy to share my slides more broadly as well. So not going to go into all of the detail, but these are the kind of things that came up from discussions and focus groups of some of the work that I've been involved with personally as well. And simple things around promoting cultural competence, unconscious bias training, developing our educators, providing a more holistic educational supervision. If there is bullying, harassment, tackling it on head on, bystander training, things that you're probably, not, sort of unaware of, but trying to make a structure so those things are kind of become more of core things that we're doing. And then making sure that the educational governance and the setup and the leadership is, sort of such that it's driving the change. So some of the things can come top down, but it can also come bottom up as well of how we develop these things. And one of the things that I'm working through is around the HE quality framework, of making sure some of these recommendations are part of the quality framework, so it will hopefully drive quality of what we do, and there's a measure of assessment as well. And then again, supporting learners, lots of different things, making sure we're tailoring according to different learning styles. A period of perhaps, you know, kind of mentoring, buddying comes up a lot from the trainees, and these have been, you know, successes to some of the programs as well. And then lots around supporting educators, which I'll talk about, and a number of different things around curricula and assessment as well. What have I been doing certainly over the last few years to share, you know, some of the work that has been going on both within the Northwest as well as nationally. So the GMC started sharing some of this data back in 2018, and this was, you know, kind of by programme, by specialty, done with mainly the leads across different regions, but now it's more accessible data as well. And based on the initial analysis, what I started to do is target schools and programmes which were both positive outliers, that you can learn from those, and then using that approach to approach some of the schools and programmes which were perhaps in some of the more negative outlying states as well. And then I've continued to work with schools and programmes to develop interventions and targeted action plans which are ongoingly monitored for effectiveness and then driving changes as well. And then are presented at various groups, whether it's like yourself at trust level, but also regional and national level, and then also at conferences as well, just to promote and drive the awareness, but also hopefully then drive the agenda forwards as well to make sure some of these interventions are being put into place. And then we started delivering a series of workshops for trainees from core programmes, and that's some of the focus group work that I presented on the earlier slides around the interventions. And that came from some of our core surgical psychiatry trainees and our medicine trainees, and I'm going to do a similar piece of work for foundation as well. And we're working with Edge Hill to develop a more of an inclusive EDI module, inclusive education. So we all do EDI modules as part of our mandatory training, but not just as a tick box. What I want to do is do this as a QI so that people can kind of learn and then take something back to their organisations to drive the change as well. And then we're doing various research work as well to again drive the agenda forwards as well. And last year we secured a bid from HEE to do this across programmes as a cross-specialty approach. And on the basis of some of the earlier work, I focused the work on core training programmes. So that's for medicine, surgery, psychiatry, and doing it with early identification and intervention. And then there's some work in the GP school that I'm trying to model, which is additional support for trainees. And I'm trying to link it with educator development programmes, so there's a more personalised support for trainees as well. And the outcomes for this piece of work is to try and improve the ARCP exam outcomes as well as the training experience, and develop a model that's going to be transferable to all healthcare and training programmes. And all this work supports the workforce strategy to expand recruitment, retention, and, you know, the various other, you know, kind of national agenda items, both for HEE as well as for wider organisations as well. And like I say, I try and use the argument of it is the right thing to do. We need to support our trainees and our trainers, but also there's a workforce argument. And when I talk about it from a workforce perspective, sometimes I get more traction and attention with some of this work rather than just saying it's an add-on nice thing to do to support the trainees. And this is the kind of strategic approach that I'm working on. So at the stage of recruitment, selection and placement, we need to be earlier identifying trainees who are coming in who may need additional support. And that could be trainees coming through the alternative training pathways. They may be new to the training programmes in the UK, and then trying to allocate placements based on educational needs, and then putting in an enhanced programme of induction to support the trainees. And whatever we do, it has to be in conjunction with educator development and training as well. So we can't just support the trainees without training up our trainers as well. So I think that aspect of work is really important as well. And if there is, you know, kind of early assessment of need or support, that needs to be done early rather than waiting for an unsatisfactory ARCP or exam outcome. That should be happening in a much more proactive way. And we know that not one set of intervention or one intervention is going to solve these issues, it has to be multiple set of targeted interventions. So need to think about it in a stepwise strategic approach. And this is the kind of work that I've been doing across the 3 schools. So I've been working with heads of school for psychiatry, surgery and medicine in the Northwest. Some of the programmes of work have become more national, particularly for medicine and for psychiatry. And we're trying to build in that strategic framework of earlier identification, induction, support, educator development programmes, and then building in an evaluation framework, because there's no point doing these things without evaluating what we do, because then it needs to change, be adapted, and then hopefully that will drive the success of these programmes as well. And one of the other pieces of work that we're doing is around the learning needs analysis tool. So this came from undergraduate work as well, of developing, what is going to work, how can we assess the needs of trainees early, and then, building in then a structured programme to assess their needs as well. So we're doing this based on a suitable framework. So we're on different phases of this work. So we've done the scoping literature review